After finishing the discussion of antiplatelets and anticoagulants, we will now discuss some mechanisms and examples on thrombolytic agents. Remember that anticoagulants and antiplatelets are used to prevent and as well to treat thromboembolic disorders, as we've taken in the last two presentations. However, how would you deal with a thromboembolic event that has already happened and has already occluded a blood vessel? Note here that anticoagulants and antiplatelets can interfere with the forming clot and prevent it from progressing further. However, if the clot has already formed and has already occluded a blood vessel, these drugs cannot on their own dissolve the clot and restore blood flow. So the solution to that is that we can use a set of drugs called thrombolytics that can dissolve the already formed clot. Remember also that one of the last steps in the formation of a blood clot or a thrombus is fibrinolysis. Remember that we said that under normal physiological conditions, under normal conditions, when you want to form a clot to, for example, repair vascular injury, you don't want that clot to keep growing indefinitely, meaning that you will have to control the size of the clot to be limited only to the site of injury. That's why we've discussed before a mechanism mediated by tissue plasminogen activator, TPA, which is responsible for the activation of plasminogen into plasmin. Plasmin then has the capability to break down fibrin molecules that make up the clot, and that interplay between new fibrin deposition to form the clot and fibrinolysis mediated by plasmin keeps the clot limited to the site of injury. Now we can, of course, take advantage of that plasminogen to plasmin pathway that limits the size of the fibrin clot and can induce fibrinolysis to design several thrombolytic drugs. Remember that plasmin is a serine protease that has the capability of hydrolyzing fibrin and destroying the newly formed blood clot, and that function can be used pharmacologically to dissolve unwanted thrombosis. So how do thrombolytics work? The thrombolytic agents act either directly or indirectly to convert plasminogen to plasmin, which in turn cleaves fibrin and lyses the thrombus. Several different thrombolytics exist, and they have slightly different ways of how they activate plasminogen into plasmin, and we will discuss those in a minute. Keep in mind that clot dissolution and restoration of blood flow occurs with higher frequency when therapy is initiated early after the clot has formed, because as the clot ages, it becomes more resistant to lysis. So, for example, if a patient has suffered from an acute myocardial infarction caused by the formation of an unwanted thrombus in the coronary blood vessels, it is ideal to administer thrombolytic therapy very soon after the patient has started developing the symptoms and signs. Delaying treatment or delaying the administration of thrombolytics will unlikely result in clot dissolution because, as I mentioned, as the clot ages, it becomes more and more resistant to the action of these drugs. Unfortunately, as the clot is dissolving in response to those thrombolytic therapies, there is always a risk for increased local thrombi formation, which might lead to enhanced platelet aggregation and even further thrombosis. So imagine that this is a blood vessel and you have an unwanted thrombus that is occluding blood flow. If you start lysing that clot using thrombolytics, it will result in the formation of small multiple thrombi that can either deposit, occlude smaller vessels, or initiate platelet aggregation. So in that case, the use of thrombolytics should be accompanied by the use of antiplatelets and anticoagulants. That's why the standard treatment for thromboembolic disorders, such as, for example, myocardial infarction, involves the use of a combination of drugs, including thrombolytics, that are often combined with an antiplatelet such as aspirin and an anticoagulant such as heparin. So these thrombolytics are used for the treatment of several thromboembolic disorders. The main therapeutic indication for these drugs is the treatment of myocardial infarction. For the treatment of myocardial infarction, the ideal way for treatment is to deliver the thrombolytic agent directly into the coronary blood vessels where the clot has already formed. And that is designed to restore blood flow to the heart. However, this is not always the case in the emergency department, since cardiac catheterization may not be always available, may not be always possible within the first 2 to 6 hours after the onset of symptoms. Remember that you need to use these agents very quickly after the thrombus has formed. And unfortunately, if in case of a myocardial infarction, if those agents were used after 6 hours after the onset of symptoms, they are unlikely to be able to dissolve the clot. And even if they did, after 6 hours, um, the myocardium has already suffered from irreversible damage. And restoring myocardial function becomes less likely. And that's why in those cases where you can't administer thrombolytic agents directly into the coronary vessels using cardiac catheterization, then these drugs can be given intravenously. And actually, this is how they are most commonly delivered, especially in the emergency departments in Jordan. These drugs can also be used to dissolve clots that result in cerebrovascular accidents or strokes. But note here that while these drugs were approved for the treatment of deep venous thrombosis and pulmonary embolism, they are not frequently used for that purpose because they can be associated with a high risk of hemorrhage. This takes us to the major adverse effects of thrombolytics. And of course, the major adverse effect of these drugs is bleeding or hemorrhage. The point here is that thrombolytic agents do not distinguish between a fibrin clot that has been formed as a normal physiological response to repair a damaged vessel wall, or an unwanted thrombus that is occluding a vital blood vessel. It cannot tell which one is harmful. So these drugs will dissolve the unwanted thrombus but at the same time, it will also dissolve the beneficial physiological clot that is used in the repair of a blood vessel wall. That definitely results in bleeding. For example, if a patient who has a pre-existing gastric ulcer, for example, and has suffered from myocardial infarction, and you decide to give that patient a thrombolytic agent immediately in the emergency department, that patient may start suffering from gastric bleeding or a bleeding ulcer following the injection of a thrombolytic agent. And that is why these drugs are contraindicated in several medical conditions where bleeding is a very critical problem. Those include pregnancy, because these drugs can result in bleeding in utero. Patients with active or healing major wounds are also at risk of bleeding if they receive thrombolytics. It is okay for these drugs to be used to dissolve a clot leading to stroke if that was the first time the patient develops a cerebrovascular accident. But if they have a previous history of CVA, these drugs are contraindicated because they can cause severe cerebral hemorrhage. They also cannot be used in patients with brain tumors, head trauma, or intracranial bleeding. And lastly, they are contraindicated in patients with metastatic cancer. The main two examples on thrombolytic agents are two drugs, Alteplase and Tenecteplase. These are the most frequently used thrombolytic agents for the emergent treatment of thromboembolic disorders. Now, Alteplase is a naturally derived tissue plasminogen activator. Remember that tissue plasminogen activator is the factor that is responsible for activating plasminogen into plasmin. And we can extract alteplase from human melanoma cells, but we can also synthesize it using recombinant DNA technology. Tenecteplase is a totally synthesized drug. It's a recombinant TPA, and it has a longer half-life in comparison to alteplase. Note that these drugs have different binding affinities to free plasminogen, meaning that tenecteplase binds more to free plasminogen in comparison to alteplase, while on the other hand, alteplase binds more to plasminogen that is already bound to the fibrin clot. That's why we call alteplase fibrin selective. So, as we mentioned before, these drugs are used for the treatment of several thromboembolic disorders, such as myocardial infarction and cerebrovascular accident. We said that we don't use them frequently for the treatment of pulmonary embolism, but you can consider the use of alteplase in cases of large, life-threatening emergent pulmonary emboli. Tenecteplase is only used in the treatment of myocardial infarction. In addition to bleeding being the major adverse effects of these drugs, alteplase can be associated with angioedema or a hypersensitive reaction, especially if alteplase was combined with an angiotensin converting enzyme inhibitor. Lastly, there are two drugs that also fall into this category. These drugs are called streptokinase and urokinase. Streptokinase is a bacterial product. It's a bacterial enzyme isolated from beta hemolytic streptococci, and it has the ability to activate plasmin by forming active complexes with plasminogen. However, this drug was previously used, was actually widely used, but is no longer available for use in the United States. It is important to know about it because it still exists in certain emergency departments in Jordan. And the same thing applies to the drug urokinase. But urokinase is not a bacterial product. It's actually an enzyme that is produced naturally by the kidneys, and it has the capability to cleave arginine-valine bonds of plasminogen, which results in its activation and conversion into plasma. Both drugs are no longer available for use as thrombolytics because of several adverse effects. Now moving to another topic, which is discussing some drugs that are used for the treatment of bleeding conditions. Remember that bleeding can happen due to multiple causes. For example, we have a set of bleeding disorders that are mostly inherited, such as, for example, hemophilia A and hemophilia B. And we can also need to treat bleeding resulting as an adverse effects of several drugs or toxins. And we've discussed that bleeding or hemorrhage is the major adverse effects of many antiplatelets, anticoagulants, and thrombolytic agents. So what are the options that we have for the treatment of these conditions? So for example, for bleeding disorders such as hemophilia A and hemophilia B, the reason behind those disorders is a genetic deficiency in the synthesis or production of certain coagulation factors. Like with hemophilia, it's either 9 or 10. So the best treatment for these patients is to replace the deficient coagulation factor. So you can give recombinant factor 9 or factor 10, depending on which hemophilia subtype the patient has. For the treatment of bleeding caused by toxins or drugs, we have several antagonists or antidotes that can be useful, and we will discuss those in a minute. But always remember that the last resort and sometimes the most efficient way to treat acute hemorrhage, especially in the emergency setting, is through blood transfusion. Okay, so most of the time, if someone suffers from a major bleeding, for example, in a car accident, and they are admitted to the emergency room, they will receive several units of blood, whole blood, of course, depending on the severity of their hemorrhage. The first two drugs that we will discuss that can be used for the treatment of thrombolytic states are aminocaproic acid and tranexamic acid. Both these drugs are synthetic compounds. They are given orally and they are excreted by the kidney. These drugs exert their action by inhibiting plasminogen activation. Okay, so they inhibit plasmin formation and then inhibit plasmin's activity to dissolve clots. Okay, so they work in a way opposite to thrombolytic agents. That's how they will reduce the risk for bleeding. Tranexamic acid is 10 times more potent than aminocaproic acid and is more frequently used. But in opposite to all the drugs that we have discussed, such as antiplatelets, anticoagulants, and thrombolytics, the major adverse effect of these drugs is to cause thrombosis. Okay, all those drugs fight or inhibit thrombosis, thus they can cause bleeding. These drugs fight bleeding or reduce bleeding, but they have the risk to cause intravascular unwanted thrombosis. Remember that we've discussed protamine sulfate. Protamine sulfate is the antidote for the drug heparin. And similar to heparin, which is naturally derived, protamine sulfate is also naturally derived from fish sperm or testes. Remember how protamine sulfate can neutralize heparin molecules? As we mentioned before, protamine sulfate has a structure very similar to heparin, and thus it can form a 1-to-1 complexes with heparin. And this is heparin, and this is protamine sulfate. Binding of protamine sulfate to heparin results in a neutralization of heparin, especially that protamine sulfate is positively charged while heparin is negatively charged. Okay, so you will form an inactive complex. Remember, a very important information is that protamine sulfate has to be administered very slowly because itself it has a weak anticoagulant activity. So you only want it to neutralize heparin. The other important antidote for bleeding is vitamin K, and we mentioned previously that vitamin K is the antidote for warfarin. It is available for administration through multiple routes, including the oral, subcutaneous, and intravenous routes. Of course, if it's going to be administered intravenously, it should be given slowly because of the risk of hypersensitivity reactions or allergic reactions. Note that for the treatment of acute bleeding, it's preferable to use oral or IV vitamin K. Subcutaneous vitamin K is not very efficient, but in all cases, vitamin K requires around 24 hours to exert its anti-bleeding effects, and that is because it is the time required for the synthesis of new coagulation factors. Remember that vitamin K is an important cofactor that participates in post-translational modification and activation of several coagulation factors. So it's necessary for normal coagulation factors function. The last drug that we will discuss in this category is the drug idarucizumab. And idarucizumab is a monoclonal antibody that is used as an antidote for the oral direct anticoagulant dabigatran. So idarucizumab is an antibody that can bind dabigatran molecules and neutralize them. Okay. Remember that as with any other drug, dabigatran has to exist in the free form in plasma in order to exert its effect. And if it's bound to idarucizumab, it loses its activity. And that's how the drug prevents bleeding that can be associated with this oral anticoagulant. Finally, this table summarizes the medications that we've just discussed, their main use in the clinic, what are the antidotes for, their major adverse effects, and which blood components you need to monitor while giving them. Like, for example, if you want to use protamine sulfate to treat heparin associated bleeding, you will be required to monitor vital signs as well as to look at certain levels of coagulation or bleeding times. Similarly, with vitamin K, remember that the blood test of choice to monitor warfarin treatment is uh, uh, INR, or International Normalized Ratio. And that's what you also need to measure when you start treating warfarin-associated bleeding with vitamin K. Thank you all for listening to this presentation. Please don't hesitate to get in touch with me if you have any questions. Thank you.